Thank you so much, Yona, for such a generous introduction. Yona and I have been teaching on this topic together for on and off for about 12 years when I was looking back on it. And it's such an important topic. It's important to me not just because of my professional role, but also because of my personal link. My mother has a significant neurodevelopmental disability, and while I always worry about her, and she's got tons of strengths and she's very resilient, I worry when she sees the regular doctor. I worry about her housing. I worry about day-to-day stuff, but I never worry more than when she's in emergency department because emergency departments are tough places for everybody. And um, when it's not kind of a place that's built for you or built to be safe and secure and welcoming, it can be even scarier. So I'm so thrilled to be here today. And I wanted to talk to you a little bit about our Emerge. So the CAMH Emergency Department is the only standalone psychiatric emergency department in Ontario. So that means in other emergency departments, I'm sure lots of people on this call have that experience where you go in, you register, you are triaged in terms of the level of need you have from 1 to 5. There's a lot of waiting, and then you see a nurse and a team and a emergency physician who will then decide where you are referred to. Are you referred to psychiatry or surgery or internal medicine or pediatrics? Our Emerge, the model is a little bit different. So everybody who walks through the door sees a psychiatrist. We have psychiatrists working 24 hours a day, 7 days a week. Or you'll see a psychiatry resident with a psychiatrist who is on site. When I first started in the CAMH Emerge, when I was a resident in 2008, we were seeing about 350 cases per month or about 4,000 cases overall per year. When I started as a staff doctor in 2012, you can see here we were seeing about 6,600 cases, which is about 550 a month. Now, if we think about our 2023, 2024 data, which I don't even have available quite yet, we are looking at well over 16,000 cases a year, which means that we've gone from seeing 350 people visiting at us every month to over 1,500. And this is an interesting piece, right? Because it can mean longer wait times. It can mean, difficulty negotiating the system. It also is an incredible opportunity for growth. So we've been through three iterations of our emergency department. Now we're right at Queen and Ossington in the center of the CAMH community. One of the challenges, though, is that in a perfect world, emergency psychiatry wouldn't exist. What would happen is that you would get the care. Yeah, we are in Toronto. We are just at Queen and Ossington. Um, in a perfect world, we wouldn't exist, right? In a perfect world, people with neurodevelopmental disabilities and their families would get the care that they need when they need it, and we wouldn't get to a point where folks would be in crisis. I think that there's been a lot of increase in mental health awareness, but I think the outpatient resources can still feel really fragmented to folks, and getting even the social determinants of health pieces that they need, housing, supports in the home, can feel really tricky. Being in inclusive and spaces, getting care for autism spectrum disorder, especially after the age of 18. These are a lot of the things that we do see in our department. So I think that there's this sort of challenge because we wish that no one would ever have to come see us. And when people are seeing us, sometimes it's difficult to know how we can best meet people's needs when there are so many needs to be met. Emergency departments are hard places. I don't have to tell all of you that. They are very noisy. There are a lot of people who are suffering in different ways, who are moving around. It's small things, like it's very well lit. Like every emergency department that I've been in kind of feels like a casino, like no windows, really bright lights, overstimulation. It's tough to know how to access food. I remember when I'm taking my daughter into the emergency department for an infectious thing, and she was little, and like I didn't know where I could get food at 2 in the morning for her. It's difficult to know where the bathrooms are. It's difficult to know who to talk to. It's difficult to know how long you're going to wait. There can be things happening there that feel scary. There can be, police and security presence, which some people might find comforting, but some people might find very frightening. Historically, emergency departments aren't a great place for gender affirming care. And so people who are gender diverse can experience misgendering and other forms of oppression and trauma. And then if you take all of that and then you move to, and also you're there for a reason, you're there for an emergency. So you're not having the best day of your life to start. The next piece is that psychiatric emergencies are particularly challenging in this kind of very stressful environment. So imagine if you're hearing voices or feeling paranoid, or you have trauma or depression or suicidality, you are already feeling pretty awful. And some of those illnesses can make us feel like we don't matter or we don't belong. Some of those illnesses can make us feel like we can't trust anybody around us. And so those things can be really, really challenging. And plus, we know that one of my colleagues who's a research assistant who has lived experience with mental illness and neurodiversity, she said it can feel, again, it's the casino metaphor, it can feel like going to play the slots. You don't know who you're going to get, if it's going to be good or if it's going to be bad. And that unpredictability can be really scary. Are you going to wait for an hour or 6 hours? That kind of thing. Am I going to be admitted or not admitted? And that uncertainty is very, very, very challenging. And I think we also see people, again, cross-sectionally. So, I think about my mom. If I know her for all kinds of reasons, she's got a great memory. She loves video games. She's got tons of friends. But if she's having abdominal trouble, or if she's struggling with a urinary tract infection, she's going to look very different to folks who see her in an emergency department. So your loved one or you yourself, you're not at the place you normally are. And so people can make assumptions about you, which is very, very stressful and can feel really frightening. There's also the sense of potentially feeling trapped as well. Like, I don't know if I'm going to get my rights taken away. I don't know if I have to stay here. And that can feel really scary, especially for people who have a history of sort of carceral trauma or being stuck in places they don't want to be. And emergency departments are hard places for folks with neurodevelopmental disabilities for other reasons around their physical health. And so when you have people with comorbid disabilities, the things that you look for, like the patterns that you look for, may be very different. So one example I like to give, and I know Yona and I have talked about this a lot, is we'll often see young people with neurodevelopmental disabilities who are more agitated, crying all the time, not sleeping, in so much distress. And it turns out, there's one case where the person may have um, a like really severe constipation. They may have bed sores. They may have terrible headaches. They may have a dental abscess. So sometimes dental stuff can get missed for sure. So I think that's a really important thing to think about. And, when people have disabilities, sometimes they're on lots of medications. And so sometimes we see people who look really, really confused, and they're like really, really sweaty and dry, and they feel awful. And it's because they had a med change, and it's hard to kind of manage all of those medications sometimes. And I think too, developmentally, when people get a bit older, when people hit menarche and they're menstruating, they may have new onset symptoms from their menstrual cycle. People may also, develop illnesses of like chronic illnesses as they get older too. And so things that like a heart attack might look different in a person who may express pain differently, or some people may have different tolerances to pain as well. So either hypersensitivity or hyposensitivity. So that's another really important point. For us in the CAMH Emerge, we are not a medical emergency department, but part of seeing people when they are in distress is making sure that we're not missing the real cause of it, or one of the causes of it. So we do have we're all medical doctors, we do have medical supports there. But another stressor for folks coming to us is they may have to get sent out to Mount Sinai Hospital for all of these investigations. And so we recommend that if you're worried about something medical, sometimes it's good to start in a medical hospital so you don't have to keep going back and forth, which is often really tricky and stressful. And I think we can't overstate the importance of life stressors for people. And so these are other reasons that people come to emergency departments. And if you're already struggling with these things, these environments become even more stressful. I can't tell you how many people I've seen who have fallen into a significant depression. People with neurodevelopmental disabilities, they get depressed. They do, just like all of us do. And so sometimes we see people who have lost a caregiver or lost a sibling, whether it's through death or change, like a new teacher or a new staff graduating from a school. We know that these folks are more vulnerable to abuse and neglect, and we have to make sure that we can advocate and support them and listen to them, because they are often their own best advocates, and we can't be paternalistic and assume we know exactly what everybody needs. We have to listen. Teasing, bullying, loneliness, and isolation. This was something that came up quite a lot during the pandemic. We'd see people who had lots of community programming, lots of volunteer work, lots of group activities, seeing friends and family, and all of a sudden you're kind of at home all day without a routine, and that's very stressful. Financial stress, and then the pressure, especially if you think about seeing a lot of people, young people, older people with autism spectrum disorder, and they often talk about that pressure required to mask or camouflage, whether it's at school or at work, I think we can't underestimate how much energy that takes and how exhausting that can be. And yeah, you might be able to make it through the day, but you may feel exhausted in the evenings, tired, angry, irritable. These are all very, very, very normal feelings and things that can affect your mental health for sure. So what do we do in the emergency department? So I think this is, I should just go back for 1 second around life stressors. I think it's really important for all of us to remember that a family is part, like no person is all alone. They're always part of a system. And we also know that when people are struggling, it affects their relationships with their family members, and the caregivers can be under a tremendous amount of stress as well. And that's nobody's fault, but that's, well, it's a system that doesn't give people the support that they need, we can say. But I think it's really important that we also try to understand that coming into the emergency department is hard for families as well, and they may be experiencing a ton of family stress, and that's really important for us to ask about and assess. And so we could talk a little bit about that too in the Q&A, but sometimes, we really want to make sure that the family member can be with their loved one and provide support. Sometimes a family member may want to talk to us separately as well, and sometimes a patient may want to talk to us separately without a family member. So we always try to ask for those three choices. And please remember, when you are in an emergency department, if you are the patient or the support person, you can always ask to speak together or separately. And everyone's voice really matters. And we understand that sometimes dynamics make it difficult to be totally honest when you're, with your mom or with your brother, and you're suffering and they're worried about you. Sometimes getting a little bit of privacy can be helpful. So what do we do in the emergency department? So this is it feels like such a black box, right? Like, you just give me 1 second. I'm just getting a text from um, the emergency department. That's a problem with my job. Sometimes you get emergency texts, but everything is fine. So thank you for your patience. What do we do in the emergency departments? I think it can feel like a black box. And I think I also want to just say, with humility and empathy, that I'm sure many of you have had terrible experiences in emergency departments and terrible experiences in our emergency department. And I think we need to approach this from a place of humility, because we often don't meet people's needs, and we can often be a place that is very, very frustrating for folks, and we need to own that so we can continue to improve. So all feedback for us is good feedback. In this slide, I'm trying to explain to you kind of what our rationale is and why sometimes things do feel really awful and may not work, and what we try to do and what supports that you're entitled to, and what goes into a good assessment. So the most important thing, remember we talked about the emergency department is very, very stressful and very, very scary, and you don't want to be there. And it's already not a great day. You're not going to look like you normally do. So the first thing that I need to do is, I can't just look at someone in front of me. Our team can't just look at someone and say, well, this is who they are. And sometimes with neurodevelopmental disorders, people might just kind of make assumptions like, oh, well, they're always screaming, or for someone with autism, they're always nonverbal. Like, we need to make sure that we actually figure out with the patient and their supports and their team, what does this person look like when they are at their best? So on the best day, the best week of their lives, who are they? What do they love? What do they like? What does their day look like? We also should want to ask about what they look like usually, because there's a bit of a difference between what you're like when you're at your absolute, for all of us, when you're absolute best, and what does sort of like the day-to-day normally look like for you. So it might not be perfect, but what can you do? What is your function? What are your interests on a kind of an average day? And then the last piece is, what is your previous baseline when you have been ill? So if a person kind of looks like how they do now, they're suffering from suicidality, suffering from behavioral disturbance, we can say, compare it to other time periods. Is this better than it was? Is it worse than it was? It's kind of like making a map of someone's life so we can see kind of where they are in their symptomatology. In general, I will say that when things change really quickly, it makes it easier for us to help and intervene, because if the things change really, really quickly and it's secondary to a physical health concern at a medical hospital that can be fixed right away, that's awesome. It's a really good case scenario. For us, if it's secondary to a new onset of mania or psychosis or depression or PTSD or addiction, we can kind of manage those extra pieces. If someone, and we see people often who a family member will say, or the patient will say themselves, like, this has been really hard for a few years and it's worse now, but we've really been suffering. Sometimes those types of problems can be very difficult to fix in an emergency department. And so it's really important for us to be transparent and honest about what we can and can't do. And I think another thing that can be really challenging is that folks are like really struggling to get the right resources into place and the right services into place. But sometimes an inpatient hospitalization, sometimes it can be super, super helpful. I'm thinking of a young woman I saw with Down syndrome who had lost a parent, who was very, very depressed, who was able to get ECT, who did great. And the hospitalization was exactly what she needed. For some other people, coming into hospital can be extremely traumatic. And if the issues are kind of around like life stressors, dynamics in the family home, bringing someone into a hospital, separating them from those places, it's difficult to do kind of behavioral work when the kind of milieu is so different, and the people there are very different. That there's a lot of team turnover. So those are some reasons why your loved one or you may be in a ton of distress, but we may not offer admission. But I think it's really important for us to be very transparent, honest, and respectful when we have those discussions. A big piece of what we do is assessing safety. The person that we are so concerned about is the patient in front of us. That is our number one priority. Do they feel safe where they are? Are they having suicidal thoughts? Are they having thoughts of hurting other people that are scary to them, that they don't like? People can often feel very ashamed and stressed when that kind of behavior happens. Do they feel like safe in the world to like get up and get out of bed and go to school? Like, do they feel like they can live a life with meaning? Those are all different types of safety. We also really would like to ask about the safety of the people around the patient. So caregivers, how safe do you feel? And that's where we may speak with you separately or together. Have there been other safety incidents that you're worried about? So all of us are like this, I always, I don't, one of the things about me that is unfortunate is I don't know how to drive. To me, I don't think it's a big deal. Like, it doesn't bother me day to day. But if you ask my husband, who has to drive me and our kids around everywhere, he may think it's a concern. So sort of knowing that different people are going to have different thresholds. So I may see someone in front of me who says, it's not a big deal, I'm not going to school. But their loved one would say, when this person is well, they love going to school and they want to be a teacher. They want to work with kids. And so this is very, very different. So that's why we ask about information from all kinds of people. Really important that we center the patient though and the family, and we don't. It's not about believing one person more than another. It's about all of us coming together to put together a strategy that works. It's really important to adapt your approach. I know that when I talk to my mom, I'm going to talk to her a little bit differently than I would talk to my brother or sister or my colleague or my friend. You still have to be authentic and engaged, and you don't want to ever talk down to anybody. But you have to make sure that you adapt your approach. Yon and I were collaborating on some work around how to best support folks with autism spectrum disorder, autistic folks, about what they need, straightforward communication, a timeline, consistency, all of those pieces. So I think making sure that we adjust our approach. We want to be respectful towards everybody, but my daughter said something recently. It's not necessarily about treating someone how you want to be treated. It's about treating someone how they want to be treated. And I think that's a really important point. Alternate forms of communication is something that we're really open to. So please let us know if there's a better way to communicate with someone. If someone has headphones on, for example, in our department, it doesn't mean that they're being disrespectful. They may be completely overwhelmed by all of the noise. Sometimes people may not feel comfortable with verbal communication, so we can bring in a laptop or an iPad, or we can bring in a pad of paper. So we do want to find flexibility in the way we communicate. There are some tools that we'll go over that can help prepare you for emerge visits and can help you kind of put that stuff into place so it's all in one place when you get there. Understanding the family environment, family dynamics. I know we've talked about this a lot, and we can talk about it a little bit more in the chat. One of the things that's really stressful, and I'm sure everyone has been through this in COVID, was I'm sure you remember during COVID, like you couldn't bring a support person anywhere really. So you'd have to kind of be alone. Even our inpatient units didn't have visitors. One of the things we were proud of at CAMH is that the foundation did arrange for iPads for all of the inpatients so they could at least video chat with people, but we know that's not enough. And especially for folks with neurodevelopmental disorders, like not having a support person there can be very, very stressful. But we're also, remember when I showed you that graph of going from 350 people to 1,600 people in a month, it can make it really tricky to have the physical space even to see folks. And so we do tend to make exceptions for folks with developmental disabilities if they're in some parts of our hospital, like the less acute side, we can keep a loved one there. There are some parts where we can't actually have a loved one, and it breaks my heart because people will say, well, can I sleep with my with my loved one in the emergency department overnight, because I think that would really, really, really help. At the same time, it's like there's a lot of like policies and procedures and challenges. So what I would say is always ask, and it's our job to work with you to figure out a plan. We've we've done some really innovative and unusual stuff, and if we can't do it, we'll tell you why, but we'll tell you honestly and transparently why. Figuring out a helpful disposition. So again, that might not be the disposition that is the dream disposition, but it's hopefully something that is value added for you in terms of where to turn next, or a medication change, or an admission if necessary. Communicating the plan. I talk very quickly, I know this, and so I tend to make sure that I write stuff down when I'm with people, just so they have it with them, asking someone to say the plan back to you, printing out a communication of the plan. So you are well within your rights to advocate. If someone like me comes in, they're seeing a million people and they tell you about the med changes super, super fast, and then they write it down and you're not 100% sure what they were talking about, you are always welcome to stop, pause, and it's our responsibility to make sure you know what's going on. We also have pharmacists available, social workers available, which is really, really helpful. Transparency and honesty, that like if we say on anything here, that's the most important thing. Radical transparency, radical empathy, radical honesty. We may not always agree, we may not always be able to do what a patient or family is hoping for, but we do want to have each other's backs and to treat you with dignity and respect. And also respect for your time. It's hard to wait in there. So in the old Emerge at College Street, if you were in, you were in. You could not go in and out, even if you like were safe to do so. In our new Emerge in our less acute area, you can go for a walk. There's a beautiful like kind of green area outside. And medical emerges, you're allowed to kind of come and go as well. So I think that's a really important piece. And respect for belongings. This is something that the team sent me ahead of time that, and it broke my heart. It's this idea that people's special blankets go missing, or their phone goes missing, or their notebook goes missing. So we have a system in the CAMH Emerge that sometimes people feel really, really nervous about it, for sure, when we take your stuff away from you. But what we do is we go work with you to record every single thing we have that you have. Whatever you can keep with you safely, we will let you keep. And then everything else will go into a locker. You'll have the locker number and it will all be returned to you, and we'll check off what was there. So we really want to make sure that we respect your belongings and your time, because there's nothing worse than losing something that's important to you when you're already like very stressed out. And then the last piece is partnerships and supports. So something like this is a really nice partnership, like our partnership with the Adult Neurodevelopmental Service at CAMH, the Israeli Center, Patient and Family Engagement Teams. We're doing a lot of research in the CAMH Emerge where patients and families are full and equal members of our study team. We have links, and our social workers have lots of links with places like Surrey Place and Griffin Center, because sometimes a lot of what needs to be done is getting those extra supports in place in the home, so people can thrive and have a behavioral plan moving forward. One of the things that we really like about, one question that often gets asked is how much training does someone like me or our nursing team or our pharmacy team have in working with folks with developmental disabilities? I think that the answer is too little. It's far too little in our residency program, but one of the things that we can do is upskill. So when we make partnerships like with our adult neurodevelopmental service, they can come and do consultations with us. These are people with highly specialized training in neurodevelopmental disabilities, and they can let us know how we can best support someone, and then it upskills us to know the best way to support someone. So we're really pleased with that partnership. And then also sort of thinking about the person as a whole, we have a very strong partnership with the Gender Clinic at CAMH. We know that, for example, gender diversity is common in the general population. It's common with people with neurodevelopmental disabilities. And so we want to make sure that we do everything we can to provide gender affirming care, not to misgender people, to allow people access to things like menstrual products, to do everything we can to support them and let them feel safe with us. And we always want to make sure that we're aware of these strategies that we're discussing to keep the patient, family safe and comfortable during the assessment. And again, this is very kind of perfect world stuff. And I know your experience may be very different. And I think that's why it's really important to have these kinds of conversations, to listen to family advocates and self-advocates so we can continue to improve the kind of care we're providing. So helpful resources. So this is, we have a link here, and this is a great tool that our colleagues at Israeli have developed. Is it Israeli, Yona, or is it Surrey Place? I don't want to misattribute it.
It was another nice example of a partnership. So our self
Yeah.
advocates and family advisors worked with Surrey Place to make these tools.
Amazing. Thank you. That's perfect. And I love to hear that because we know this in my research in suicide and suicide prevention that you can't actually care for anybody if you don't know what they need and want, and they're the experts in their own care. So that collaboration is so important. And so this is something called my coping tool. You know how we talked about this baseline issue? This way it allows someone to talk about like what stress looks like for them and what are their strategies for feeling better when they're distressed. It's also really useful because if the doctor says, well, have you thought about X or Y? You can say, yeah, and here it is, and this is what I usually do. Or if you're working with a nurse and you're feeling kind of stressed, then he or she can look at it and they can say, well, hey, do you want to try this together? So this is really, really useful. The more information you can bring for us, the better. Sometimes these tools are great because sometimes if you bring like a chart that's like 80 pages, it can be really daunting for the team to be able to process that all and read it. So short communications that are sort of really high yield are really helpful for us. And this is another co-created tool called My Hospital Form, and it can be prepared ahead of time. This is so great, right? Because you know how sometimes you just want to make sure people ask you the right questions, and sometimes we don't know what someone's level of function is or what someone's experiences of healthcare are. So something like this can be very, very, very useful. So I think another thing that is so frustrating is when you have to tell the same story over and over and over again. And this is a function of like team-based assessment. It's also a function of change and handover. So when we have something like this is really, really, really useful. So we can make sure that the information doesn't get lost and we can, can not repeat information a gazillion times when you're with us. So that's the end of the presentation.